My name is Dr. Larry Gelman. I'm an associate professor at the University of Manitoba, a visiting lecturer at the University of Nairobi, and the senior manager of the University of Manitoba projects in Kenya. The University of Manitoba has been working in Kenya since 1980, has built several structures for the University of Nairobi, the most recently being the building behind us, which was constructed between 2004 and 2006 with funds from the Canadian Foundation for Innovation as well as the University of Manitoba. It houses laboratories, including one of the few enhanced level 3 laboratories in Africa, as well as offices for the University of Manitoba, other collaborating partners in this collaboration, and the University of Nairobi Institute for Tropical and Infectious Diseases. Since we started working in Kenya in 1980, the University of Manitoba has basically been focused on sexually transmitted diseases and HIV/AIDS. And much of the information that we know about the natural history of HIV/AIDS in Africa comes from the research conducted by the group, the University of Nairobi, University of Manitoba, and its collaborating partners.
And the collaboration has been extremely fruitful. Initially we started with the department, and now through this collaboration there has been an expansion which has led to other international institutions getting involved, in addition to other departments within the University of Nairobi being involved. In fact, based on this expansion, we have now established an Institute of Tropical and Infectious Diseases to coordinate these research activities that have been taking on for the past years.
And this research project has generated a lot of novel information, both on infectious diseases and sexually transmitted infections, as well more recently on HIV. The research program is important because research leads to the next development of care. So the research that we're doing today will be the care that's provided to patients in the future. Care and research go hand in hand. You can't have a research collaboration without providing care for the individuals that are in your research study program.
We've also, over the last 5 years, with the support of the American PEPFAR program, begun to offer treatment and care and prevention services to a larger community, which has included the opening of the swap clinic in downtown Nairobi, as well as coming up in the coming months, opening of other projects and other clinics elsewhere in Nairobi, serving what we call most at-risk populations, which include not only sex workers, but also intravenous drug users, men who have sex with men, and other populations that are at very high risk of contracting and transmitting HIV/AIDS.
Up to about 2006, we had about, I would say basically, 2 main clinics. That's Pumwani, where we basically took care of mothers and children. And then in Majengo Clinic, it's a dedicated sex workers clinic. In 2006, we went out, flat out, to actually do mobilization within Nairobi. And in 2006, we got a grant in 2005 from the Gates Foundation. And it kind of, that grant required that we increase enrollment of our patients to the Majengo Sex Workers Clinic. So in 2006, we went out, flat out, to actually do mobilization within Nairobi. And I think, if I recollect, we mobilized about 2,300 sex workers within a period of 1 year. And but surprisingly, what happened is that out of those that were mobilized, out of the 2,300 sex workers who were mobilized, we only managed to get about 770 to the Majengo Clinic. And that was good for the study in terms of the Gates Foundation studies, but kind of left us wondering exactly what was going on, because about 2/3 of the ones who had been mobilized were still selling sex within Nairobi, were not being rich with services, and we decided to do something about it. Gates Foundation is primarily, funding research activities, and we decided to approach CDC Kenya, which was kind of friendly towards providing what I would call prevention services. And what we did is we put up a small proposal whereby we proposed creating what we call a sex workers outreach program, SWOP.
The model is not so much research, it's more care. It's about educating the sex worker, providing preventive services, treating screening for STIs and treatment and ARV therapy.
So our program is heavily focused on research, but also has a very strong care component, so that the research of today becomes the care of tomorrow.
We are about 17 staff here. We have 1 physician, and we have 5 nurses, and we have a prevention officer. We have 3 counselors. Those are the kind of the people who are working here. We also have a driver who is on standby. The location was key, where they will not be stigmatized, and where they will not be pointing a finger, where the police will not harass them. Second, we identify staff who can be willing and open-minded and engaging, not judgmental. The same thing with the counselors. We are providing what we call a prevention package, and we are using the national guidelines for the sex workers, which stipulate on what to give when you set up a program for the sex workers. One of the services that we give is health education. We train women and the men who sell sex on how to prevent themselves. We give them life skills, and we also provide condom and show them how to use it practically. And once they are here, we again give them another health education, which explains to them the nature of STI they are likely to get. We also give them STI treatment and testing. Then we give HIV testing and counseling, and we also give ARV here. We give what is called post-exposure prophylaxis. For somebody who has been raped out there, or somebody who has had a condom burst, we give them that to prevent spread of HIV again. And we also give family planning for the female. We are currently serving almost 6,000 female and male sex workers. We still don't have very many male sex workers. We have about 300, the rest are female sex workers.
SOAP has really helped me this clinic, because I had vowed never to do a HIV test. Because initially I had when you're in sex work, you get like condom births. I mean condom ruptures or tire births, that is what we call them in the street. So when I used to have so many of those, I didn't know so many things, but I insisted on condoms. So I had vowed never to take a HIV test. But when they came to the clinic, I was counseled and I agreed.
Actually, the whole group of the MSWs and the sex workers, especially even the female sex workers, most of them now they are doing very well, and their life has changed. And the people who you used to see that they are HIV positive, when they came here like they were dying, they have risen up, they have returned to people, and actually, unless I tell you I'm positive, you won't know I'm positive. And it's that courage to accept my sexuality, to accept that I'm a sex worker and I'm also, HIV positive. It takes courage, but that courage we have gotten from SOAP.
I get free medical service. I know now so much. I know also my rights. I know so much about the use of condoms, how to protect myself in case I get any kind of infection. I know how to go about it.
I want to see other SOAP established. Not only this kind of model, even if they are smaller. Why am I saying I would like to see this? It's because in our country today, we still not been able to stop the spread of HIV. And as long as we ignore sex workers, as long as we ignore MSM in our country, we are not going to stop it.
The HIV prevalence in terms of the total number of HIV women infected coming through the clinic is about 32%, but for the men is about 46%. So it means we are targeting the group that really requires the services. And from the data, again, on entry, the sex workers, both men and women, only about 30% know how to use condoms, collectively use condoms. So you can imagine people who sell sex, but they don't know how to use condoms. So that was actually another surprise for us. So we've been now doing a lot of health education, a lot of demonstrations in terms of condom use. And by and large, what we're trying to do is to make sure at least this high-risk population is armed with the right information and the right tools to actually prevent HIV transmission to the general population.
Welcome to Pumwani MCH Clinic, which is a collaborative research clinic between University of Nairobi and University of Manitoba. Our main work here is care and treatment, and there are also research activities. So as you can see, this is our reception. When the patients come in, they get into touch with our data clerk, to whom they give their cards. Their files are retrieved, and we have a waiting area here. So after that, once their files are retrieved, the next step is to go to triage, which is this side. So this is the patient's first station once they come to the clinic. Here they are triaged, meaning their vital signs are taken, their weight, their blood pressure, temperature. And at this point, a decision is made on whether this patient has come just to collect drugs or the patient has a problem and needs to see a doctor. Basically, this clinic has one doctor, 3 clinical officers, about 8 nurses, 2 counselors, 1 data clerk, and 1 cleaner. Currently, the clinic has about 4,000 active patients, out of whom around 1,800 are on ARVs. This clinic is mainly a referral center from the various facilities within this locality. So due to space constraints, we have been forced to erect these tents, which serve as extra consultation rooms. So like this room here is used for counseling. All new patients are counseled in this room. There are not a lot of privacy. And like now you can feel it's too hot. When it's cold, it's too cold. We usually have problems with mosquitoes once in a while. But yeah. This last tent here doubles as our TB clinic. It also doubles as our prevention with positives coordinating office. So all our TB patients pick their medication here. All our discordant couples also come here. And all people we are trying to do any preventive activities also come to this room. We also have prevention with positive activities. We have about 110 discordant couples whom we are trying as much as possible to ensure that the negative partner still remains uninfected. We also have a pediatric clinic which is manned by a consultant pediatrician, and currently we have about 60 children on ARVs. But I'm happy to say that our prevention of mother-to-child activities are working very well, such that of late we are not seeing HIV-positive children. The last 1 year they were about, I think, only 3 or 4.
Hii clinic imenisaidia sana tangu nianze hiyo 92 vile nili give birth. Nimekuja nimepata usaidizi mingi, nikikuwa mgonjwa natibiwa, hata mtoto vile akikuwa mgonjwa anatibiwa, hata mzee akikuja anatibiwa for free, unapatiwa back transport yako, na nimeona iko na usaidizi mingi sana. And then daktari ukiwaongelesha they are not harsh. Ani wanakusikiza vizuri sana.
The small girls, they normally come here during the holidays. They visit here once, that is after every 3 months. If they are not sick, that is the normal routine of the clinic. So they come, they are checked, they are given drugs, they are dewormed and all that.
Hizi madawa za OIs hizi, ukienda kwa hospitali nyingine unanunua, lakini hapa tunapata for free. Hizi ARVs pengine unaweza kumeza na zipatani na mwili wako. Na hizo hospitali zingine hata ucomplain haipatani mwili wako, hawatakubadilisha sababu pengine hawana hizo dawa. Lakini hapa ukisema hii dawa haipatani na mwili wangu, watakubadilishia dawa. Sasa mimi naona hii kifungwa maybe nitakufa tu kwa sababu sioni vile nitaendelea kuishi.
In the first place, I would like to thank those responsible for having put such a clinic here, because it's something rare, especially in the kind of a country we are living in.
From the reception to the triage area, next the patient comes into this building. As you can see, there's not enough space. It acts as a reception, it's still the filing area.
and patients actually wait around here. And you can see most of these boxes actually contain ARVs, and we don't have any other storage space. So we have to keep them here. As they are consumed in the pharmacy, then we restock the pharmacy. This is where all the samples from the clinicians' rooms are stored as they await transportation to our labs at Kenyatta. We actually enroll almost 20 patients every week. So our numbers are growing. Demand for our services is increasing every day. So one of the things we will definitely need is more space to offer those high quality services, more space for storage, and also more clinicians, more nurses, and more data clerks, so that patients get the highest quality of services.
This clinic started, I think, in 1984. Initially, it was an STI clinic, but HIV and AIDS research is the mainstay of what we do at this clinic. We recruit our clients, actually, we recruit them for research using a peer-led mechanism. So we have one individual who the women feel is vocal, can represent their interests, is known to most of them, and that lady then will identify other sex workers. They then come to the clinic. We have screening techniques to actually make sure we are talking to the right people, that we are actually dealing with sex workers and not just maybe housewives. There's one medical doctor, that's myself. I have a clinical officer. Then we have nurses who also double up as counselors, so they play both roles. They're also trained at dispensing medication, but recently we got a pharmaceutical technicians. In addition to research activities, we run a huge comprehensive care clinic here. So we are providing care for HIV and AIDS. We are providing also treatment for opportunistic infections. So far, we have about 700 women who are HIV positive. About half of that are on ARVs. The patients will then are required to come in every month or so for just a checkup, just to make sure they don't have any recurring STIs. They get the results for all tests we do. They get their results. There's a turnaround of about a week.
Currently, this is what we are using as our VCT room. Then she will be, the counselor is going to counsel the client, and then they will agree whether she wants to be tested or she doesn't want to be tested. But most of the times, the patients opt to be tested, and then from testing, then they will go for a pelvic exam, because being sex workers, they need to be done a pelvic exam to establish whether they have any STDs. Then they will get into this room where they will be done the pelvic exam after the doctor has established what their problem is, and then he will prescribe the medication for them. If they had come for research purposes, we do some bleeding. We will take some blood for the research purposes. Others is to establish if they have STIs like the syphilis. And from there, if they are HIV positive, we will do the CD4 count.
Mimi nimefaidika kutoka hapo, nimefaidika sana. Nilikuwa mdogo msichana. Nilikuwa ale hapo karibu 82 hapo. Na vile nilikuja hapa nimesaidika sana. Kwa maana hata nimekaa nikaguduliwa magonjwa mengine hapa tu. Magonjwa mengine kama ningekaa nyumbani singejulikana. Lakini vile nimekuja hapa nikapata nikakuwa na pressure. Sasa nikakaa tena nimepatikana na sukari. Na ninaendelea tu na hii kliniki imenifanyia mengi sana.
Fortunately, the grant that we've been running on has allowed us to give them free medical care. So as a benefit to being involved in the study, we give the women free medical care for most outpatient illnesses we're able to treat. It's only when they get too complicated that we then have to refer to the national hospital, which is Kenyatta. We're not reaching all the sex workers that we could reach, and so we'd have to increase our outreach services. We might have to start catering for men who have sex with men. There's a growing population in Nairobi that is also a most at-risk population and probably is driving the HIV/AIDS epidemic. So that's probably a group we would have to start dealing with. But that's a peculiar group that requires their own separate services, and comes down to what I've been talking about: space, space, space.
In this facility out here, we are doing cutting-edge research. Now, previously, what used to happen is we'll get samples from these women and they'll be shipped to Winnipeg, Manitoba, whereby the scientists out there will look at their immune system. But right now, we've been able to get cutting-edge equipment, which has enabled us to actually do the analysis right here in Kenya. Now, this is good in the sense that then we are able to deal with fresh samples rather than frozen samples. Usually when samples are frozen, they lose viability. So the ability of us to actually look at the immune system right out here in Kenya has really enhanced the capacity of us to be able to do that.
I'm the chief of the special pathogen program that is managing the biosafety level 4 in Winnipeg, Canada. This is the National Microbiology Lab that is part of the Public Health Agency of Canada. I'm very impressed, I have to say, with the building behind me. There is a great capacity for diagnostic, including biocontainment labs, and these are very important for the local population, but also for Canadians, and that I think is very important to mention. It is a great place to isolate emerging and re-emerging viruses and other infectious agents, and these are essential for us to keep our diagnostic tools up to date.
I am Erastus Hirungu, and professionally I am a medical laboratory technologist. We receive different kinds of samples on a daily basis. We have a central reception area whether they are all received and checked whether they match on the correct samples. How are they handled? How are they collected? How are they labeled? How are they transported? From the reception, these samples are transported to the different laboratories. We have different laboratories here which do different tests on different specimens. From the lab, the results are actually communicated back to the clinics. We used to do it manually, but currently we have been blessed with an online system of taking our results back, posting our results back to the clinics, which is actually very effective and very fast. There are also samples actually which are collected for research purposes only. Cells like peripheral blood, mononuclear cells. We don't do any testing on those samples here. We just isolate the cells, freeze them, and ship them to Canada for research purposes. That's where they go develop some research protocols on small scales or from samples from the clinics. Then they come back to here and do research now on the ground here on a wide scale.
One other beauty about this is that we are able to actually train scientists for further work right out here in Kenya rather than them going outside. So for that matter, we actually have MSc students who have enrolled for their work out here, and in fact, some of them have already finished their MSc, and one is actually enrolled in a PhD program. So this will enhance our capacity to be able to do cutting-edge research right out here in Kenya.
So the three big advantages of this facility is the biocontainment lab on site here in Kenya. Another big advantage is the training capacity of this building. It is, I think, very important to mention that a facility like this will be key in training infectious disease expert and specialists, and that will be also of value to local populations here in Kenya, but also in Canada back home after a training here.
The impact of the program has been seen in a variety of areas. Perhaps one of the more significant results was the circumcision trial in Kisumu a few years ago that was conducted by the University of Illinois, University of Manitoba, and University of Nairobi, that has led to global policy changes regarding male circumcision as a prevention for HIV/AIDS. Our research has demonstrated that over the last 20 years, condom use by sex workers with their clients has increased from almost nil to close to 80 to 90%, which we consider to be one of the more significant aspects of the project.
Aside from the training and the diagnostic side of things is the outbreak response. So this is a very important component that the special pathogen actually is specialized into. And with this facility here, we can keep equipment and keep training to a level where we can contribute to outbreak responses in the region and in sub-Saharan Africa. And it's also important to us to be trained and efficient at handling those outbreaks, because we also face them back in Canada. And the H1N1 in 2009 was an example of this. SARS was another example. So this is it. This is a very impressive facility here in Nairobi again, and I think I'm really looking forward to see the great work that's going to come out of this place.
I think it is one of the best collaborative activities in this country, and the future is wide open. It is very promising, and we would want it to continue forever, not only for the 30 years, but much more years, many more years to come.
Well, there are always challenges. I mean, 25 years on, there's still a high level of stigma about HIV/AIDS in Kenya. It's still not a topic that's widely discussed. The issue of dealing with these most at-risk populations, such as sex workers and men who have sex with men, who theoretically are still illegal in Kenya, is a challenge. I suppose our biggest challenge is just resources. Resources for the kind of prevention and treatment and care programs that we feel are needed. The Kenyan government is donating a little, other donors are donating some, but the need is great. There's still not enough funds, and despite all of the work we've been doing, we've basically been operating on a shoestring for the last 30 years, and we would like to be a little bit more secure and have the resources to expand our program in the areas that we think need to be expanded, providing better quality, providing better levels of monitoring and evaluation, and making sure that as few people as possible miss out on the treatment and prevention opportunities that should be available to everyone.
Over and above getting money to provide the necessary support, there are other things that are being left out that are very, very important in terms of programming. So infrastructure has been left out. You need space to provide these services. You even need additional tools to provide these services, but they are non-existent.
There are all these challenges that keep on arising, and I suspect that as we go on, more research questions will continue to arise as we solve some questions, as policies and programs are instituted at the national level. There will be more issues that will arise. So I suspect that there will be continued challenges, continued research questions, and continued need for more research and programs for many years to come.